Good afternoon, everyone. On behalf of NAAOP, I'd like to thank you all for joining us today. First off, I'd like to thank Paul Prusakowski for offering his efforts to set up this webinar for us. This webinar is free of charge to both NAAOP members as well as non-members. If you are not a non-member, I urge you to visit the website at NAAOP.org and consider joining. We need your continued support to represent O&P patients and providers in Washington to advance quality O&P care. The NAAOP George and Dina Brees Fellowship is upon us. We have selected a candidate that we are excited to announce next week. If you would like to support the fellowship program, please visit NAAOP's website and you can donate under fellowship. Today, our presenters are going to be talking about challenging Medicare Advantage denials of O&P care. We originally did this webinar last July. I'd like to start out with a disclaimer that this presentation is designed to provide accurate and authoritative information on the subjects covered. However, it should not be considered a fully comprehensive legal analysis, and the speakers are not engaged in rendering any legal advice or other professional services. Today's agenda, we're going to kick it off with some introductions. We'll review the purpose of this webinar and provide an O&P provider and practitioner perspective, setting the stage on Medicare Advantage and prior authorization, the new rules for providers and patients in challenging Medicare Advantage denials. We'll wrap up the session with questions and answers, and then parting comments. Introduction to the speakers today. So myself, Ann Moss, I am president of NAAOP, and I have a provider practice in Western Pennsylvania based out of Pittsburgh with 19 offices. Peter?
Thank you, Ann. My name is Peter Thomas. I'm the General Counsel of the National Association for the Advancement of Orthotics and Prosthetics, and looking forward to today's webinar. It is a redux in a sense, because we did do a very similar webinar back in July, but we'll go into why we're doing this again in a moment. George?
Thank you, Peter, and thank you, Ann, and especially want to thank you, Paul, for all of your efforts that you do for NAAOP over practically every month. I want to just follow up on what Ann said about joining the NAAOP. Those of you that are on this call that are members, we thank you. Your help is critical to our efforts on Capitol Hill with CMS and the VA. And if you'd like to help the NAAOP Fellowship in some way, you can go to our website. The bottom of the home page is a donate to the fellowship. And there's also a join link where you can join NAAOP if you're not a member now. Thank you for being a part of this webinar. And Ann?
All right. So the purpose of this webinar is CMS has issued new informal rules to rein in the overuse and abuse by Medicare Advantage plans of prior authorization to deny claims. These new rules offer all providers, including O&P practitioners, of patients and a whole new toolbox to challenge denials of O&P care. Most O&P denials are occurring at the prior authorization stage, and these rules address this area in depth. This webinar is designed to furnish O&P practitioners and patients with tangible, usable arguments backed by citations to the new regs to secure coverage and payment for their patient services. So as an O&P provider and practitioner perspective, you know, as I stated earlier, I am president of Union Orthotics and Prosthetics Company in Pittsburgh, Pennsylvania. I am partners with my brother and sister, so we're a family business. We have seen a lot of Medicare Advantage denials. And again, particularly at the prior authorization stage. And oftentimes you're provided a very vague denial that doesn't make any sense. I know we have an authorization department that submits most of the prior auth requests, and they would almost prefer just to have straight Medicare. because Medicare is black and white. You have the LCDs to follow. You have a whole set of programs for how it works, where a lot of times with the Medicare Advantage plans, you're getting the runaround, and then you're having to try to go and fight these. And I think with the stressors of all of the challenges administratively that we are facing today, between audits on the back end, prepayment audits, denials that just don't make any sense. The administrative staff is burdened, and it's a big challenge at this point. So a lot of people, I think, just simply might not challenge it and just tell the patient they can't get that K3 prosthesis that they should absolutely be eligible for. So I'm happy to see you are all here today, because you are the group that is here to challenge this. And this is what we need to do. We need to fight for our patients to make sure they're getting what they deserve. So. Peter?
Thank you, Ann. Okay, so I mentioned that this was a redux of a similar webinar we provided in July of 2023. And the reason is because in July 2023, the rules had not fully gone into effect. There's a whole new set of Medicare Advantage rules that took place and took effect in full force on January 1, 2024. And so we wanted to make sure that people really understood that these new rules were out there, that you can use them to your advantage, and that you should be using them to your advantage. And so I went to the leadership conference in early January. We've talked to our membership, talked to our board, and I just got the sense that there were a number of folks that didn't really have a good awareness of the fact that this was now available to them. And so the reason we have decided to do this webinar again is not only to reiterate this and make sure that people are fully aware of it, but also to answer any questions that people might have. Maybe they're already using these rules and they're not getting very far, or maybe they have a success story they'd like to share. So we thought this would be an opportune time to present this information one more time and see how the field reacts. So need to give you a little bit of background. The Medicare program now covers MA beneficiaries to the tune of 1/2. In other words, half are traditional Medicare or fee-for-service, and half are Medicare Advantage. That's an incredible growth of Medicare Advantage over the years, and it looks to be continuing to grow. And that's a problem. That's one of the reasons that it's really been elevated on the radar screen of Congress, CMS, the Office of Inspector General, and others. So many people, so many beneficiaries, about 30 million now, are being receive their Medicare benefits through Medicare Advantage plans. These are private plans that Medicare pays a per member per month fee, and ultimately it's a capitated system. I know the statistics in inpatient rehabilitation is that fee-for-service beneficiaries, or I should say MA beneficiaries, get 1/3 the access to IRF care, inpatient rehab hospitals, that traditional Medicare beneficiaries receive. And I can assume that it's the same way in orthotics and prosthetics. So we've got to do something about overly aggressive Medicare Advantage plans. And I think we have a nice toolkit, if you will, to try to do that now. Why did these new rules come out? Well, the Office of Inspector General for the Department of Health and Human Services issued a report in 2018. And that report basically stated explicitly, and these are their words, not mine, that MA plans were misusing and abusing prior authorization to limit their payments to providers and protect their profits. This was what the OIG concluded. That's a stunning conclusion. They didn't sugarcoat anything. They recommended a series of reforms. In 2022, they followed up with another report and found similar findings with respect to widespread misuse and abuse of prior authorization by Medicare Advantage plans. CMS, the Centers for Medicare and Medicaid Services, then went ahead and issued some new rules that came out last year and that applied in full force on January 1 of this year. We all know that Medicare Advantage plans in the O&P field are notoriously restrictive. They don't cover the same benefits that the traditional Medicare beneficiaries have available to them. They are much more reluctant to approve more advanced technology, and they make you jump through many hoops. Now, I don't want to suggest that the traditional Medicare program doesn't do the same thing, but with the MA program, they have the effect of actually thwarting access to care. Next slide. Okay, so what are these new rules? First off, they were issued in last year, April 12th. So we're coming on about a 1 year that they issued these new rules. They reform prior authorization and other utilization management techniques that are routinely used by MA plans. They took effect in June of 2023, but until the plans actually were required to publish and distribute to beneficiaries the new rules and incorporate those new rules into their plan documents, that was when the rules took full effect, and that again was on January 1, 2024. The goal is to help level the playing field between providers and MA plans, and of course, providers and patients and MA plans, to make sure that patients get what they need. These regulations are a real blow to the Medicare Advantage industry. They've had a pretty pristine track record in preserving their access to the Medicare beneficiaries in terms of their marketing techniques, their payment levels. That's starting to change. I think you saw back in the fall that CMS actually prohibited MA plans from issuing over 1,000 different television ads that were viewed as misleading. And they continue to get paid about 20% more per patient than the average patient under fee-for-service would extract from the Medicare Trust Fund. So the original goal of the MA program was to contain costs, and they're certainly not doing that under the current configuration of the program. Next slide. So new tools to challenge the MA denials. What are these new tools? Okay, there are a series of regulations. This is regulatory language that you can cite when you are talking with MA plans, typically in the context of a peer-to-peer visitation where you sit down or get on the phone or Zoom with someone from the MA plan and hash out whether that beneficiary should get access to care, when you're essentially challenging their prior authorization decision. One of the key things that the new rules do is ensure or mandate, stronger than they used to mandate, that MA plans must use traditional Medicare coverage rules. And we'll go into that in more depth. They also limit the use of internal proprietary guidelines that MA plans routinely state that they're permitted to use and routinely use to deny care. They limit prior authorization to only certain situations when they're determining medical necessity and confirming benefits, and we'll go into that. They strengthen medical necessity determinations. They establish guardrails around utilization management tools and techniques, and even marketing techniques. And they strengthen the qualifications of claims reviewers. That's a really important one for O&P because it is fairly specialized. Coverage guidelines. Let's start there. Current Medicare statute and regulations already require that all Medicare Advantage plans provide coverage of items and services that are covered by traditional Medicare. That has not changed. That's been the standard since the inception of the MA program. But the new rule clarifies this and extends the protections and makes it a stronger requirement. The MA plans must, and this is regulatory language now, they must make medical necessity determinations based on traditional Medicare coverage and benefit criteria, and they specifically call out the Medicare statute, regulations, national coverage determinations, and local coverage determinations. And as we all know, there's some regulatory language, some statutory language. There's not many NCDs in O&P, but there's pretty detailed local coverage determinations for sure. And that is going to be, that explicit reference to LCDs is something that you can cite. And when they say to you, we're not covering this care, and you know that it's contrary to a local coverage determination for prosthetics or orthotics, you should cite 42 CFR section 422 101B2. Now that sounds like a lawyer. That sounds really wonky, but that's going to tell them that you know what the new rules are. They may not even know these new rules. So you may be educating them. CFR means Code of Federal Regulations, CFR. It's basically the book of regulations that the federal government relies on. So whenever you're making an argument, if you throw in a citation, it could really benefit you because it demonstrates to them, again, that you know what you're talking about. You're just not making this up. They also prohibit coverage based on internal, proprietary, or external clinical criteria that are not found in traditional Medicare policies. So there's oftentimes when MA plan will deny coverage for a prosthetic component or a prosthesis or a custom orthosis, and they'll say, well, our internal guidelines, we follow Milliman, we follow Interqual, whatever they may follow. They may create their own, and we don't cover that. Well, that's not acceptable. They can't do that. And if they ever give you an indication or suggest to you that they're not covering the care that you've requested for your beneficiary that the physician has signed off on, and they say, well, according to our internal guidelines, they're not medically necessary for this patient, you need to challenge that. And again, that is found at the Federal Register. That's different than the Code of Federal Regulations. But ultimately, you can cite 88 Federal Register at page 188. I laugh because page 22,000, but that's what you can cite, and that's where they'll find it if they challenge it. At the Federal Register, it specifically says Medicare Advantage plans may not use Interqual or Milliman coverage guidelines criteria or similar products to change coverage or payment criteria already established under traditional Medicare laws. So they have to follow traditional Medicare. And if they're not, you need to push back on that. All right, so in terms of internal coverage criteria is not necessarily prohibited outright. Medicare Advantage plans are permitted to utilize internal coverage criteria, but in only in certain situations. They have to demonstrate that coverage criteria are not fully established in applicable Medicare statutes, regulations, NCDs, or LCDs. So they have to assert that the LCD in our instance does not sufficiently detail what's covered and what's not. Now, I have no illusions about this. We will say that the LCD is quite detailed and offers significant guidance to MA plans to determine coverage. And they will nitpick. They will say, well, it doesn't specifically say, right? We know that the plans are going to try to get around this. But this new set of tools is not the end of the line. It's the beginning. It's the start of a new framework that we can build upon in years to come. So your experience in what they say back to you when you say you can't use internal guidelines because the LCDs already are fully established and established coverage in this area, we want to hear from you if they're pushing back on that and they're opposing that. So coverage criteria are deemed not fully established when there's an absence of any applicable statutes, regulations, NCDs, or LCDs, and obviously that's not the case here. Orthotics and prosthetics is in the statute. 1861 S9 establishes coverage for artificial arms, legs, and eyes, back, neck, and spine and leg braces, or that's the language they use in the statute. There's also regulatory language. There's clearly local coverage determinations that establish criteria. So that doesn't mean that tells me that coverage criteria in this area does not satisfy the not fully established criteria. NCDs and LCDs include flexibility. We know that. So that explicitly allows for coverage in circumstances beyond the specific indications that are in the LCD or NCD. And finally, the unspecified criteria are needed to interpret or supplement general provisions in order to determine medical necessity consistently. Again, I would say that most of these provisions do not really apply to O&P in the sense that there is very specific LCD language on coverage and coding and payment of all of these different components and care that is provided under the O&P benefit. I think we can move on. All right, so what if the plan does say, well, we don't know about a particular area, we don't see any real specific coverage criteria under traditional Medicare, so we're going to create our own internal MA procedures or coverage policies. They are permitted to do that, but they need to follow certain evidence. They need to base their policies on current evidence that is widely used treatment guidelines or clinical literature. So we're not talking about some hastily thrown together user studies or things of that nature. We're talking about acceptable, they define acceptable clinical literature as large randomized controlled trials, prospective cohort studies with clear results, published in a peer-reviewed journal specifically designed to answer the relevant clinical question, or large systematic reviews or meta-analyses summarizing the literature of the specific clinical condition. That is a really high standard. We rarely have those types of studies in O&P. So they're not going to be able to find many of those kinds of studies to use for an internal guideline. So be cognizant of that. They can't just say, oh, well, our evidence suggests that this patient doesn't need this particular prosthetic component, for instance, and here's a study to prove it. Well, is it a clinical, is it a large randomized controlled trial? Is it specifically designed to answer the relevant clinical question? Is it a systematic review or a meta-analysis? If it's not those, you've got a good argument to push back. So unpublished evidence, evidence that is in a case series or a report, evidence that is derived solely from the MA plan's internal analyses, their own claims history, those are all not meeting, they don't qualify as meeting this standard. Next slide. Further information on developing internal procedures. When MA plans do develop internal procedures for deciding what's covered and what's not by their plan, they must provide in a publicly accessible manner both the internal coverage criteria and a summary of evidence that was considered during the development of that internal criteria used to make medical necessity determinations. So it's got to be public. It's got to be transparent. There's many instances in the past where MA plans have used what they deem proprietary guidelines, where they don't share with you what those coverage criteria are, and yet they still assert that based on them, they're going to deny the claim. That's no longer possible under these new rules. They also say that the MA plan must have a list of resources of the evidence that is publicly accessible. The plan has to publish an explanation for the rationale that supports the adoption of the new coverage criteria used to make this medical necessity determination. And when the criteria is not fully established, the plan is required to identify the general provisions that are being supplemented and to explain how the additional criteria provide clinical benefits that are highly likely to outweigh any clinical harms. So in that instance, if they are going to delay a decision, that's a clinical harm. They have to demonstrate that the evidence is strong enough to outweigh the delay in making their decision. All of that can be cited as CFR section 422-101. Next slide. All right. What about medical necessity determinations? The MA plans must make medical necessity determinations based on all of the following factors. Whether the provision of the items or services are reasonable and necessary, the patient's medical history, as you can imagine, they have to consider the diagnoses, the conditions, the functional status, physician recommendations, and clinical notes. Not just it doesn't say in this particular rule, clinical notes of the prosthetist or orthotist, but that is federal law. Coverage and benefit criteria from the traditional Medicare program, and where appropriate, involvement by the medical director of the MA plan. So that's where medical necessity decisions, or that's what medical necessity decisions must rely on. MA plans have to ensure that they're making determinations based on the circumstances of the specific individual, as opposed to using an algorithm or software or artificial intelligence that does not account for an individual's circumstances. So it's got to be a independent, or rather an individualized determination of medical necessity. And many times that is not happening. They will put in the clinical circumstances of a given patient, and they'll spit out an answer as to whether they cover a particular type of prosthetic knee unit or foot unit or custom orthosis or whatever it might be. So it has to be an individualized determination. Prior authorization is a specific type of utilization management, and that is restricted to certain types of prior auth. The final rule establishes safeguards regarding prior auth, and it limits it to 3 circumstances. It needs to, well, the safeguards are in place to avoid disruptions in care, to limit the MA plan's ability to partially approve what a provider ordered, and to minimize repetitive prior authorization. So if they say to you, well, we'll authorize X, but we're not going to authorize the entire prosthesis, that's no longer something that they are permitted to do. And prior auth is supposed to not inordinately delay the care to the patient that's taking place. The course of treatment language is very important. A course of treatment for a prosthesis may be several months, could be at least several weeks, to have an assessment, an evaluation, an initial fitting, perhaps test sockets, additional fittings, and alignments, and starting to ambulate on a particular type of limb, having the patient bring it home, coming back, refining it further, fitting it further, ultimately winding up in the delivery of a prosthesis and billing to the Medicare program. I would define that as a course of treatment in prosthetics or custom orthotics. And ultimately, that language is addressed. The course of treatment issue is addressed in these new regs. Prior to the approval of a prior authorization request for a course of treatment must be valid for as long as medical necessity applies. So that's again to avoid disruptions in care, and in accordance with the applicable coverage criteria, you consider the patient's individualized medical history and the treating provider's recommendation. When a patient switches to a new MA plan, either from an existing MA plan or from the fee-for-service plan, the traditional Medicare program, into an MA plan, they may not disrupt a course of treatment, and they are required to provide authorization for those services up to a 90-day period. They cannot require a reauthorization or an active course of treatment for new plan enrollees for at least 90 days. So there is continuity of care when someone moves from the fee-for-service program to an MA plan, or from MA plan to another MA plan. And then finally, this requirement applies even if the services are furnished by an out-of-network provider. Okay, MA plans may only use prior authorization to confirm the presence of diagnoses or of other medical criteria that are the basis for coverage, for basic benefits to make sure that the benefits are included under the plan, and to make sure that they're medically necessary, and for supplemental benefits to ensure that the provision of the service or the benefit is clinically appropriate. Many MA plans do cover supplemental benefits. That typically doesn't impact O&P, because O&P is considered a basic benefit under the Medicare program. If an MA plan approves the provision of a covered item or service through a prior authorization or a pre-service determination of some kind, it is barred from denying coverage later on the basis that that there's a lack of medical necessity, or from reopening such a decision for any reason except for good cause, or if there's evidence of fraud and abuse. Now, if there's evidence of fraud and abuse, all bets are off. CMS and its contractors and the OIG can pretty much open any claim they want, but they cannot come back after a prior authorization request has been approved and deny that claim based on medical necessity. That's an important rule to know. And it's an important protection that when you go through prior authorization under the MA program, once you get that approval to provide Medicare medical care or O&P care to that patient, they cannot come back and deny that claim based on medical necessity. Now, can they come back and reopen the claim if there is a question as to whether there was a delivery, a confirmation, or whether there was some other problem with the claim? They probably could establish good cause to do that. But good cause is a particular standard. They can't just say, oh, well, we're just opening it up just to see. They can't do that. They have to have some, in the law, in the criminal law, they call this probable cause, some probable cause that a claim should not have been paid when it was. Finally, the new requirements should help reduce the incidence where O&P claim disruptions, care disruptions, and delays and denials of care are a result of misuse or abuse of prior authorization. Next slide. So utilization management is something that's been around for a long time, not just with MA plans, but with all private insurance plans, really. CMS updated these utilization management regulations that apply to MA when they issued this final rule, when it particularly pertaining to internal coverage criteria. For instance, the MA plan must establish a utilization management committee that is led by the plan's medical director if the plan utilizes policies and procedures. But this is not necessarily new. This is something that's been on the books for quite some time. Now we start to get into new rules. The MA plan is prohibited from using any policies or procedures, including prior authorization, on or after January 1 of 2024, unless the committee reviews and approves the policies and procedures. So the committee has to review it and approve it, and it needs to be done at least annually. So if by some chance the MA plan is able to get past the fact that they have used internal guidelines and not relying on traditional Medicare coverage criteria, if they can argue some of the other issues that I've just covered around why, that the evidence base is sufficient and that they were public and transparent about publishing this, you can always ask them, was this reviewed by the Utilization Management Committee, and was it done within the last year? And if it was not, you've got an argument to say this needs to be covered. Next slide. Here's a really important provision. So many times O&P providers have come to me and said, the people reviewing these claims don't know the first thing about orthotics and prosthetics. I have no idea what their credentials are, but they're using terms that don't apply. They don't understand why this foot goes with this ankle unit and why they're different. They don't understand why you have a suspension system and a sleeve or a liner. They're essentially uninformed about O&P care, and yet they're making decisions about medical necessity. So the new MA regulations created new requirements for the reviewers of these claims at MA plans. If the MA plan denies a prior authorization request or the claim is based on medical necessity, the determination must be reviewed by a physician or other appropriate healthcare professional with expertise in the field of medicine or healthcare that is appropriate for the services at issue, including knowledge of the Medicare coverage criteria. So Another avenue you can use is to push back and say, who reviewed this claim? Who denied the claim? What were their credentials? Were they a physician or other appropriate healthcare professional who understood prosthetics and orthotics? The CMS expects that the physician or other appropriate healthcare professional has specialized training, certification, or clinical experience in the applicable field of medicine. So I would not suggest that O&P is the applicable field of medicine. I would suggest that probably rehabilitation medicine is the applicable field of medicine, maybe neurology, maybe I'm sure there are rheumatology. There are other types of specialties that might be appropriate, podiatry for assessing a claim in this area. But ask the question. They need to tell you who reviewed the claim and what their qualifications were. The physician and other healthcare professional is required to have a current and unrestricted license to practice within the scope of his or her profession. I must tell you, if you raise that issue, you're probably going to get some pretty terse responses. If you're saying, are you licensed? It's very unlikely that MA plans are not going to license these professionals that they employ to do this work. But it is another requirement. And then finally, if an MA plan reviewer does engage with you in a peer-to-peer consultation to talk about a particular patient's prior authorization decision, and there's a treating physician involved during the adjudication of a determination, this policy would apply. So knowing that that physician's credentials is important, and you have a right to know it. All right. There are a few caveats with respect to qualifications. CMS didn't want to overly burden MA plans to have to hire a specific consultant to just adjudicate a particular type of claim. So they did put a couple of, I'd say, limitations on this right to know who's reviewing the claim and right to know what their credentials are. The policy does permit MA plans to determine on a case-by-case basis what constitutes appropriate expertise based on the services being requested and the relevant aspects of the enrollee's health condition. So the plan kind of decides who is qualified to review the claim and who isn't. I can tell you that that's probably going to be something that CMS strengthens in the future, because that's a pretty decent sized loophole. Well, we determined that, give me an example. We determined that, I don't know, this particular physician, this general practitioner was appropriate to adjudicate an O&P claim. That may wind up getting strengthened in the future. The final rule also does not require the reviewing physician or healthcare practitioner to be in the same specialty or subspecialty as the treating physician or other healthcare provider of the service or item. So, for instance, a denial of O&P care does not have to be made solely by an MA, a Medicare Advantage orthotist or prosthetist, or a Medicare Advantage physical medicine and rehab doc. There could be others that are qualified to make the decisions. But obviously, they still need to have specialized training and knowledge of the medical area in which they're adjudicating. CMS also did not adopt a policy that said that the reviewer has to have a minimum number of years of specialized training in the field of medicine related to the service at issue. And it stated that it wanted to provide some flexibility to MA plans to manage clinical staffing resources. So those are some caveats, but if you need a stronger argument in terms of who reviewed these claims and why they don't know what they're doing, reference the previous slide and the regulatory citation that was listed on that slide. Slide 20. So what does NAAOP think of this MA rule? First off, let me just say that, MA has been kind of the congressional darling of Congress, bipartisan, for years. Whenever they have an MA hearing, there's usually kind of an overflow of positive comments. More recently, that's changing. There's been some real scrutiny that CMS, the Office of Inspector General, and congressional leaders in particular in some of the health committees, have been imposing on MA plans, especially now that we've tipped the balance and the majority of Medicare beneficiaries are now MA beneficiaries. There's additional scrutiny, and I expect it's going to continue to ratchet up. So I do think that this new set of regulations is a major advance for all healthcare providers, but particularly O&P practices who do experience routine delays and denials of care. Given the growth of the MA program, these standards are critical to maintaining access to care in the future. At least they can be, if they are implemented and if we hold MA plans' feet to the fire, no pun intended. CMS did not wither under the pressure of the MA plans and the insurance lobby. They strongly opposed this rule. CMS could have whittled down and kind of weakened this rule when they published it, but they didn't. To their credit, they created a new regulatory framework that I think beneficiaries and providers can build upon in years to come. There's no doubt that the MA plans will try to subvert these rules. They'll try to get around them in whatever way they can. Some might be so brazen as to just ignore the rules, but we need to report that. We need to make sure that CMS knows this, so that when we go to them and say you need to enforce these in a more strong way, in a more stringent manner, they'll have specific instances. They won't just be hearing from providers and patients about the negative implications or the negative experiences they've had with MA plans. And finally, the final rule is a major step forward, but it is something we can build on over time. Unfortunately, some of the early indications are that enforcement is going to be a continuing challenge. I'm not sensing that there's been a sea change in how MA plans are now behaving, that they all of a sudden have opened the spigot to additional access to care now that these rules are in place. That's one of the reasons we're doing this MA rule webinar again, so that people use these rules, become familiar with them and facile with them, and try to get and push back every single time an MA plan denies care based on either prior authorization or for some other reason. Next slide. All right, so that's our presentation. We do have some time for Q&A, and I really am hopeful that people will ask questions. We're going to move toward Paul Prusakowski to moderate this section of the webinar.
All right. First of all, thanks everybody for participating. We will be putting a recording of this presentation up at the NAAOP website. That will be available for a limited period of time starting early next week for those who could not attend that registered, and for those of you who did attend. Also, there's been a number of questions from people requesting individual copies of the slides. They don't have to scroll through the video. Decks and additional information will be available as PDF to members. So if members make a request to us, we'll send it to you. If you're not a member, if you go to NAAOP.org, there's a join. We do these webinars, and everything Peter and the team do to support this profession are only made possible through the active contribution of people like you. Small, mid-size, or large contributions are all very welcome. So yes, they will be made available to members. You can become a member on the join section at the NAAOP website. And we have a few great questions out here. So maybe the first one was early in the session from Samantha Merrick for clarification with the use of interqual. Should the MA not be using that criteria at all? If someone wants to hit that.
They cannot use MA interqual criteria as the sole reason for denying the claim. If they say, well, we're denying the claim and it's based on interqual, that's prohibited. They can only use those internal guidelines or other types of proprietary guidelines that they may have if they can demonstrate that the Medicare coverage criteria for fee-for-service beneficiaries, traditional Medicare, does not fully address the issue that's at hand. And the LCDs, you can argue, largely do that. if they find some scenario, and if you can point to something in the LCD specifically that where you can say this is fully addressed, this is fully established coverage under traditional Medicare, you can't use any other guidelines. This is it. Then the interqual or Milliman or anything else is null and void. They can't use it at all. If they can demonstrate, and you should push back on this, if they can demonstrate that the guidance that or the LCD in a very specific area is not clear and needs to be expounded upon, they then have to go through all of those requirements that are listed in this webinar that I just went through: public notice, backed by sound evidence, transparently issued, available to the public. They need to do all of those things. They need to have that available. They can't just say, "Oh no, it's interqual, and we're going to deny the claim." So that's where you use those new tools, and I would cite it with reference to the regulations so they know that you know what you're talking about.
Thank you. There's another one we'll bounce around a bunch. Trevor Townsend. For the L codes that require traditional Medicare fee-for-service prior authorization, is the same required of the MA plans? And is there a way to get prior auth from Medicare itself that is applicable to the MA?
Okay, the prior authorization requirement under the traditional Medicare program is not directly applicable to MA. MA can do what it wishes, and they impose prior authorization on a whole lot more than the relatively minor number of codes, few number of codes, principally for advanced technology prostheses, that is imposed on traditional Medicare beneficiaries. So there's no requirement that MA plans use that same or use prior authorization to approve those codes. But they typically use prior authorization in orthotics and prosthetics much more broadly than that anyway. The second part of that question, Paul, is what?
Is there a way to get prior auth from Medicare itself that is applicable to the MA?
Not really understanding that question. Look, what NAAOP feared was that prior authorization under the traditional Medicare program for this limited number of codes to which it applies was going to treat O&P more like durable medical equipment, which does have prior authorization for certain types of durable medical equipment, in particular mobility devices, not all of them, but some of them. And we weren't clear as to what impact prior auth would have in the traditional Medicare program, and we generally did not like the idea. We've been essentially learning through the grapevine that many providers, many suppliers, many O&P practitioners actually have gravitated toward prior authorization under traditional Medicare because it's better than providing that component and then having a post-payment denial and having the funds recouped while you've already expended the resources to the manufacturer. You can't take it back from the patient. And so you're left with a double whammy. You've paid the manufacturer, but all of your reimbursement's been recouped. And then you sat in a ALJ queue for years on end. That's changed somewhat now. The ALJ queue has largely been addressed. But nonetheless, compared to that, prior authorization is actually quite favorable. And I think we no longer would take the view that it's necessarily a problem for O&P, especially for those more advanced, high-end, kind of fairly expensive components. But I don't think that we're interested in trying to expand prior authorization in the MA program. They do plenty of prior authorization as it is. Again, the benefit of prior authorization under these new rules is that you're barred from being denied based on medical necessity once it's been approved through prior auth.
We have a lot of great questions here, so hopefully we can get through them. We've got Susie Ebersbach. She's asking a question. We have repeated denials using PIM 83C13 that employs 13.5.4, one that meets but does not exceed the patient's medical need, to assert that the requested prosthesis exceeds the patient's need. Peter, can you read this? Because it's a lot of detail on this in the Q&A.
To be honest with you, that's a question that I'm happy to answer or try to answer offline, but it's really, really detailed, and it's nothing that I think I'd want to try to answer off on the fly like that. I just need to look at that a lot more closely.
Yeah,
So is there a way you could preserve that question and
I will.
get back to that?
I absolutely will. Okay. There was from Christina Moore. UHC recently updated their MA policy using a combination of their own policy requirements as a form of quality assurance or standards of review. Have you seen this, and do you have any thoughts on this?
I have not seen that. They may issue policies where the existing traditional Medicare fee-for-service policy is not fully established, as we learned from the webinar earlier. But again, they've got to do it in the right way. Did they have a utilization review management committee review it and approve it? Is it based on sound evidence? Is it available to the public? Is it were they transparent? All of those requirements have to apply. And so I would look at that policy closely. And if you feel as though they've gone beyond what they're able to do or permitted to do under these new regs, you should most definitely challenge it. How do you challenge it? Well, you could write a letter to your MA plan and lay this out. You could report it to us. You could report it to the Medicare program, 1-800-Medicare. Just start getting complaints logged into that system. Many people feel as though that system, is a black hole, doesn't go very far, but the more complaints we start registering with CMS, the better. And we can help register those complaints as well from an association perspective.
Yes, actually that answers two questions we had, because somebody was asking, how can we as clinicians or admin O&P help enforce or report what we feel is abuse? I think you just hit that. Let's see, there's another one on UHC from Melissa Antonucci. UHC is using the draft version of the LCD to deny members from K2 through K3. Any suggestions on that?
Strongly opposing that. That is a draft LCD that was never adopted. In fact, it was retired in 2017. And now there is a pending policy to actually cover K2 amputees with MPKs, fluid and pneumatic knees as well. They can use that to their peril. I mean, that's not traditional Medicare program current guidance. It's certainly not an LCD that ever went into effect, and you should push back on that hard, whether it's through the individual person that you get on the phone and ask to speak to their supervisor or the medical director, write a letter to them, let us know, as you just have. That's important that we challenge that.
Okay, there's a few more from Samantha Merrick. I'm trying to combine these to see if they're related. One was related to their MA plans that utilize partial approval determinations regularly, especially when K3 components are requested in prior auth. How do we know if they're abusing medical necessity denials or partial approvals?
Well, if they're denying part of it, but not all of it, they are denying based on part of the claim, a partial denial. And the Medicare Advantage program regulations now prohibit that. It's in this slide deck. Feel free to go back and look at that part of the regulation. By the way, those citations to the regulation, if you feel as though you have no idea where to find that, take that CFR citation and drop it into a search engine. It'll pop right up. I mean, just Google it. It'll pop right up on your screen, and you can read it in context and read exactly what it says. So most definitely push back on any kind of a partial denial.
Now, there's another question from Samantha. It says to clarify, but I'm not certain it was from the same exact piece. It may have followed through the Trevor Townsend question line. It says to clarify, if the patient is in their first 90 days of a new MA coverage and we had a prior auth from Medicare or another MA, are you stating that prior auth should stand with the new MA?
Yes. Up to a 90-day period. They're not supposed to change. They're not supposed to impose a new prior authorization. They're not supposed to change the prior authorization. They're obligated to continue the course of treatment through a 90-day period when that person comes on board to a new MA plan